Assalamu alaikum and good afternoon to everyone. I hope everybody have enjoyed the morning session. We are going to start our second session, Oncology Nursing, which is session Oncology Nursing 2. And again, I'm going to introduce our renowned speaker, Mr. Andrew Dymek. He is the Acting Chief Nurse and Lead Cancer Nurse, Royal Marsden National Health System Foundation, Trust London. And he will talk about nurses' contribution to quality and patient safety in cancer care. Mr. Andrew, we kept you busy this weekend and hope you enjoyed the previous session. So the floor is over to you, please.
Thank you very much, Ms. Rahana. Again, for those who are new to or joining this session, thank you very much for the invitation, and it's an absolute pleasure to be here with you all. Unfortunately, we can't be face-to-face due to our current circumstances, but I do hope that sometime in the future we're able to meet and continue to share and learn amongst each other, but we will do this in a virtual aspect. So I'm just going to share my screen, one moment there. Okay. So thank you very much again, everybody, and good afternoon. It's early in the morning, but it's wonderful to be here. So I'm going to go through now the nurse's contribution to quality and patient safety in cancer care. So very briefly, thank you again for the introduction. I'm a cancer and intensive care trained nurse from Australia, but I've worked in Sydney, Dublin, and the United Kingdom. And as Ms. Rahana said, I'm the acting chief nurse of the Royal Marsden Hospital. I'm also a board member of the International Society of Nurses in Cancer Care. So very briefly, for our new attendees, the Royal Marsden, where I work, is the world's first hospital dedicated to cancer diagnosis, treatment, research, and education. It was founded in 1851 by Dr. William Marsden, and we treat adults, teenage young adults and children, conduct clinical research and clinical trials, medicine and surgery, and we also host the Royal Marsden School of Cancer Nursing and for allied health professionals. So again, just very briefly of my role in the International Society of Nurses in Cancer Care. We're an international organization of nurse leaders, improving health and well-being of our patients at risk or living with cancer. And importantly, we promote the role of the nurse, improving cancer care internationally, developing nurse leadership and cancer delivery. And we were established in 1984 as a global community. And very proudly, we have the Pakistan Cancer Nursing Forum as one of our members. So now I'm just going to go through some of the areas around quality. It's broken down in two sections, quality and patient safety, looking at how cancer nurses can contribute from a local or the ward-based area to more of a regional or a global perspective. So importantly, we really need to look at how we define quality of care. Now, this can be taken in very different aspects internationally. So again, as we were discussing earlier, many of our definitions are transferable across countries or regions, but other things really need to be interpreted and managed appropriately in a local setting. So when we're looking at defining quality of care, this description here is really looking at the WHO classifications. And as an example, some of these elements here are used by our regulators, for example, in the United Kingdom, to look at how we perform as a hospital or a setting. So the first key thing really is looking at safety, or how safe are we as a service? As we know, we need to minimize risks. We have to report incidents, avoid preventable injury and medical errors. But we all know providing healthcare is a risky business at times, but it's how we mitigate those risks. And many ways, nurses are at the forefront of this. We are assessing patients, we are treating patients, and we are able to quickly identify if there's a potential problem. However, from a nursing perspective or a cancer nurse perspective, the ward nurse or a specialist nurse is doing multiple tasks in a very busy clinic or a clinical setting. So again, there is always an element of human error. We need to ensure that we have effective services. So those services are based upon our scientific knowledge and evidence-based guidelines. So we have a wealth of nursing research in terms of how we then continue to look at our services. And in particular in cancer nursing, we've got lots and lots of evidence around patient experience, treatment effects, or outcomes. We also need to consider the timeliness. So where possible, when we're looking at quality of care, and again, nurses play a really key part in this, about reducing delays in receiving or providing care. So again, from a clinical setting, but also with a nurse-led clinic or an advanced nurse practitioner role. So it's how we can ensure that our patients get access to timely cancer care where appropriate. The efficiency component is again pertinent to us all. So how do we maximize the resources that we have? In particular, this doesn't need to be around a physical, but time. So a cancer nurse's time is increasingly important. But then also, how do we capture that time that the nurse is undertaking those clinical roles or other aspects of their role? And again, looking about reduction of waste. And again, that can become from a consumable or also from a person's time. Really, really importantly, it's our equitability. So in cancer care, it's ensuring that we ensure that the care doesn't differ according to personal characteristics. So making sure that all patients have access to the appropriate care that's required at any time. And we really need to make sure that this is people-centered. So we need to consider the preferences and the aspirations of the individual. So looking at actually what is relevant, what's appropriate, and what's the right model for the area or the patient population that we are serving. Really, what's very, very clear and becoming more important for us to consider is we've gone very much more in terms of around the patient experience, but particularly how that links also into staff. So I'll just cover a couple of points here. So in terms of quality, we know we have to reduce harm events, but as we were describing earlier, harm events sometimes do occur, but as a nurse and a cancer nurse, there are certain elements of care that the quality or the patient safety sits firmly with us. One example is a reduction in nosocomial infections. So we heard earlier this morning from Rosina looking at the critical care setting around infection. So across cancer, we know our patients are immunocompromised, they're susceptible to more infections. So MRSA, Clostridium difficile, and currently obviously with our COVID-19 pandemic. So we're at the forefront around ensuring that patient experience linked to some of the nosocomial infections are addressed. So looking at how we get our patients' voice and feedback. So regular finding out or audit or understanding of surveys of what actually the patients feel. So just one thing that I reflect upon in my times as a critical care nurse, in cancer critical care nurse, new intervention, lots and lots of medical evidence about how that intervention would work. And the physiological effects, but there was no evidence of actually, well, what does it mean for the patient to have this intervention? And from a very MSc project, we're able to change the way that we delivered a certain intervention in the intensive care unit by listening and asking the patients, how does this work for you, rather than just looking at the medical side of it. And some very, very simple things could be changed to make sure the patient experience is better, which then led to an improved patient experience and improved quality. So importantly, we more and more see how patient experience and staff experience are intricately linked together. So if you have a very clear understanding of what the patient experience is and what the staff experience is, they'll provide a better service and ongoing care. So it's now moving more than just looking at that patient experience, but thinking about how we work as a team, how we work as professionals, and how we work with our colleagues. So bringing all that together really does help for delivering a quality service. And as we move in, as medicine advances, it's that personalized care. We're seeing a huge change in the way that we deliver cancer care with immunotherapies, with various other systemic anti-cancer therapies, and very much so around the specific treatment for an individual patient that is disease specific for that individual, rather than just a blanket approach of treating one patient with an intervention for everybody. So, and that goes down to that level of that personal interaction. And again, cancer nurses are at the forefront of this delivery. So then we move into the patient safety element. So just looking at a definition again, we're thinking about the WHO description. And as we described earlier, that healthcare delivery has a certain degree of risk. We know this is there, but it's how we mitigate and how we manage that risk. And importantly, as a cancer nurse, it's how we identify potential risk and eliminating harm where possible. So when we think about that, we then think about what is, or in terms of the definition, is that absence of preventable harm during the process of healthcare, and how we reduce that harm to an acceptable minimum. Now, we know any error or harm, we don't want it to happen at all. However, again, we need to remember that we work in complex environments in a complex system with many various different people, and it's really important to try and understand the level of risk and to minimize that. But we'll always aim to have no risk, but again, that's very challenging, obviously. And again, from a cancer nurse perspective or a individual practitioner, it's looking at how do we mitigate these risks. So looking at our local policies, our leadership, the data that we collect, and then quality improvement projects. So as we've probably all heard at many points at one time, is that we get compared many times from a quality and a safety perspective to the aviation industry. Now, it's very, very easy for us to look at it in a simple matter, but again, in very simple comparisons, we've got a complex organization delivering complex care and treatment, and you've got a very controlled environment of an airline or a pilot in a cockpit. So again, there are certain things from industry that we can learn and put into our healthcare settings. So I'm just putting that into context. So again, these are WHO, some key things around patient safety. So 4 out of 10 patients are harmed in primary and ambulatory care settings. So again, that's nearly 50% of our patients that come to us for treatment and care who have a harm incident. Now that could be a medication error, or could be another more serious issue. When you're looking across internationally, so there are 134 million adverse events that occurred in low and middle income countries, which contributed to 2.6 million deaths annually. So we still have lots of areas that we need to improve. And remembering, no cancer nurse or no healthcare professional comes to create harm, but it's our systems that we need to work on to ensure that we have the robust support and guidance to ensure that we minimize that risk. Common for us, we deliver a huge amount of medicines. So whether that be for pain control, in end-of-life care, critical care, or delivering chemotherapy. And those medication areas that cost an estimated $42 billion a year. So I'm just going to use one example of a patient safety change that can be going across various different clinical settings. So this is an example of a handover from an operating theatre to a critical care setting. So again, and learning from industry. So many of us may have heard of this model. So looking at the airline industry, but also the Formula One racing industry, where you've got a complex situation at a pit stop that needs to be lots of information, lots of people handing over at one point, but making sure we don't have any error. So if we then look at these areas, the way that those safety themes have been broken down, it's looking at leadership. So whenever we have a situation in a clinical setting, it's looking at the leadership. So if we use this example of a handover, it's who's in charge, clearly defining who that person in charge is, and then looking at how we then take that forward. Looking at the tasks that need to be done, or a task sequence. So again, in this scenario, looking at the handover. So somebody allocated to do equipment and technology, somebody looking after information, and other ones looking at a plan. Then there's the task allocation. So who is doing what? So an anaesthetist may look after the airway, the critical care or the cancer critical care nurse is looking after drains or monitoring. Then having a clear predicting and planning process. So look at what safety checks need to be undertaken. Who's checking the safety aspects of a ventilator? Then going on to the discipline and composure. Again, one person speaking at a time. And in a critical time of handover, we know this could be from a ward to ward, shift by shift basis. If there's lots of disruption, vital information can be lost. Then looking at the checklists, so where appropriate, having checklists. But again, look at how we manage that in a clinical setting. Making sure that we've got all involved. So we've seen this many, many times in patient safety aspects when an individual doesn't feel able to speak up because the most senior person they feel is know what they are doing, but we expect everybody to talk together to make sure that we can continue to have a safe environment. Briefing before, during, and after. And really, really important is that situation awareness. So for around patient safety and cancer care. So if you're having a patient in a medical day unit having a reaction to chemotherapy, for example, is the ability for somebody to stand back and see what actually is going on, because we can get very caught up with the actual situation and lose situation awareness. And that obviously then leads into training. So how do we contribute? So frontline healthcare professionals is looking at our data collection about safety. For us that are in managers or in support staff, it's look at how we work with other clinicians to learn feedback and action on safety information. For board members, again, for those nurses that are in that capacity, it's looking at sure we have the right resource for safety to be aware of and quality and safety metrics. And then again, as we move further, the nurses' role in particular around government, regulator, and national agencies. So really key that nurses with clinical backgrounds have access or educational backgrounds are able to design systems that oversight and ensure regulation and for organizations to demonstrate their safety. So then moving on to specific contribution for clinical. So every clinical nurse, we collect, analyze, and respond to local measures. So we want to see the early warning signals of quality and safety issues. So again, earlier on, we were discussing some of those nurse sensitive indicators. So harm-free care element, for example, or a bundle that might be in a clinical setting. So again, with many of these items, this is solely down to the cancer nurse. So looking at pressure ulcers, falls, medication errors, sepsis, and VTE. So when we are thinking about these and what's our role, we have that clear front role of ensuring that the safety aspect of care is delivered. And if we start seeing these trends increasing, we need to address what is causing that trend. And most often it's a system that is the issue rather than individual. So how do we ensure that we build safe and appropriate systems as clinicians to support particularly our junior colleagues that are coming in to nursing and cancer nursing? So again, we then take that further, looking at our mortality rates. So, what else is happening with our patient population? Are they linked to some of the harms, or are they linked to some other issues? Just to give an example, many people are familiar with the WHO surgical safety checklist. So this is an example of how nursing and specific clinicians take some of the evidence and move it on to a different aspect. So in the United Kingdom, we also have to look at local standard invasive procedures, or LOCSIPs. So this is using an international tool to ensure that procedures that are undertaken that are invasive, that we use the safety checklist in terms of building upon the WHO surgical safety checklist. So this goes out beyond the operating theatres, and this fits in with advanced nursing practice or practice of nurses in a clinical setting. So this procedure is then undertaken for nasoendoscopes, ascitic drains, chest drains, or interventional radiology procedures. And again, nurses are at the forefront in delivering these. Another area is around nurses' contribution in terms of the operational aspect of an organization. So in particular, important to us all in every clinical setting is ensuring that we've got right staff, the right skill mix, and how we link that to patient acuity and dependency. Thankfully, no longer we just look at individual bed numbers, but we actually look at what's happening to the individual patient on a clinical setting, whether it's in a medical day unit or whether it's in an inpatient ward, and have we got the right skill and staff to meet that patient needs. And as we know, we could have 4 patients who are who are not dependent or acute, or you could have 4 who are very dependent and acute, and you need a different level of skill of nurse and a number of nurses to manage those patients safely. Then just looking at this is an example of a framework for measuring and monitoring. So in terms of ensuring you've got safety, measurement and monitoring, there are various different aspects we need to look at. So first one is looking at patient harm. Has the patient care been safe in the past? And we're looking at particular incidents and see if there's any wider system issues. And look at that learning and feedback mechanism. The reliability, are our clinical systems and processes reliable? So again, looking at local and national audits and standards, and then measuring that reliability. Sensitivity to operations is looking at is our care today safe? And we should ask ourselves on a day-to-day basis in all of our practice about safety of a day-to-day care. Then looking at anticipation and preparedness. Will the care be safe in the future? So looking at our trends, what do we need to change? What do we need to help move things forward? And then finally, the integration and learning. Are we responding and are we improving? So if we find a problem, how do we take it to the next level? And finally, just to give an example of a global patient safety collaborative initiative. So looking at how we work internationally and together with the WHO or other countries or regions together, and how we need to focus on patient safety. So the key things really from this example is around leadership, education, training, and research. So leadership, really prioritizing our patient safety, promoting patient safety culture, and engaging patients and families. So again, going back and asking individuals, including our staff. Build from an education perspective is building a competent, skilled, and compassionate healthcare workforce.
5
And
more
then the
minutes,
research,
Sandy.
thank you. And from research is to enhance the research capacities and evidence-based policy and processes in patient safety. So again, this is a good example of how international partners and regional colleagues can work together to ensure that we've got patient safety. There's National Patient Safety Days as well. So in summary, quality healthcare is essential. We expect it for ourselves, we expect it for our relatives. So every day that we go to work, we need to look at how we can continue to deliver that with a learning process or a quality improvement methodology. There is a link to patient experience. And as we said earlier, that link then also goes on to staff experience. Nurses lead and deliver on patient safety. We monitor, we assess, and we change practice. So again, in many healthcare settings, the nurses are at the forefront and will always be at the forefront in ensuring we've got safe services, particularly in cancer care. And nurses' contribution is from the front line to the government and body regulators. So again, it takes one of us to make a change, and it makes one of us to ensure that we have a more safer quality service in cancer care. Thank you.
Thank you very much, Mr. Andrew, for talking about nurses' contribution in patient safety in cancer care. And while going through your presentation, I was thinking that there are many things which we can adapt here, and there are many things which we are already doing. I would like you to please stay with us and enjoy the rest of the session. Our next speaker is Ms. Mukaddas Sarwar. Ms. Mukaddas is a senior nursing instructor practitioner at Shaukat Khanum Memorial Cancer Hospital and an oncology specialist nurse. She will talk about nursing staff competency building to reduce chemotherapy administration errors. Ms. Mukaddas, the forum is over to you.
Yes, thank you, Ms. As Ms. Rehana already introduced me, my name is Mukaddas. My clinical area is chemotherapy, where 40,000 to 45,000 patients receive chemo every year. My title of presentation is nursing staff competency building to reduce chemotherapy administration error. I'm here to share my experience regarding how chemotherapy nurses are not just preparing for safe administration of chemotherapy, but how they are being enabled themselves to prevent the harm before happening. Why it is necessary to do such measures? Because anti-cancer medicines are high-risk medicines, and chemotherapy has a very narrow therapeutic index. A tiny change in dose may impact adversely, and even minor change in sequencing in the drug administration may harm the patient, and change in BSA calculation may left our patient underdose or overdose. Shaukat Khanum recruit nurses from general setup. They don't have prior chemotherapy knowledge, so it is our duty to develop them. Unintended chemotherapy administration error can happen, and they prove to be lethal when they happen. Near miss is a term which used when we stop the error before reaching to the patient, and worldwide data shows us that many medication error go unreported. What standard of practice says? American Society of Cancer Pharmacists recommends, and Oncology Nursing Society and American Society of Clinical Oncology agree that reducing the chemotherapy administration error, hospitals should know the risk and train the staff. How did we identify our risk? The documented evidence of 2017 reviewed from our hospital and quality improvement opportunities of 2017 showed that there are a number of preventable errors. And if we don't follow the administration policy, drug administration policy safely, these following population like patients, healthcare providers, and environment can be on risk. What risk a patient can have? They may have wrong medicine. They may being overdose or underdose. Sometimes they may receive medicine of another patient. They may have contraindicated medicine, and they may have chemo without informed consent. Sometimes there may be insufficient information is provided to patient to manage their own side effects at home. What risk factors can reach to the healthcare if we don't follow the proper guidelines? Healthcare professionals, especially nurses, those who work on bedside, they are high risk of having mishandling and may harm their eyes. If they work ungloved, they may have dermal exposure of cytotoxic drug. And if they work unmasked, they may have inhaled medicine. Indigestion, another problem. Needle sticking injury is another issue. Why and how environment can be risk in cytotoxic environment? One risk is of spillage, and that can be happen when infusion bottles are faulty. And if we don't know how to handle cytotoxic drugs, and when we want to remove the air from the syringes and we use improper technique. Let's see our 2017 data. It shows that in that year we have administered cytotoxic medication to 37,262 patients. And worldwide data shows that intercepted worldwide chemotherapy administration error 2 to 5%. Although our patient had very minute established error in that year even, it was 0.06%. But we do concern because every patient does matter to us. In that year, total 47 error reported, and among them there were 23 those were the established error, even though there was not a big harm reached to the patient, but these error happened. And in that year, only 15 near miss we catched. And we actually started to work on it on same year. And we have see what are the preventable error happen in if we see the types of that error. And we noticed that there were 3 incidents where there was a risk of harming nurse to themselves. There was a wrong patient administration, wrong order for 3 patients, wrong dose, spillage occurred for 3 incidents, and wrong documentation happened for 1 patient, wrong dilution, wrong dispose of, no consent was seen for 2 patients, and without consultant verification, there was 2 chemos, and there was a 1 patient with the Baxter pump, a CIV removed, and 1 starvation happened. What we did for capacity building, actually this Swiss model, SKCS model shows that there are checks and there are systems in place, but every system have there are holes inside, and if one system recognize their fault immediately, and that doesn't go to other systems, but for reaching harm to the patient, all systems should have gone through the same hole. I mean, every system should have some some chances to pass through that risk. When medication is a combined effort, I mean, this is a process. So when physician order the medicine, if error can recognize at that time, it doesn't reach to the patient. And when pharmacist prepare that medicine and they recognize, that doesn't go to the nurses. But see, the nurses are the one who is immediate before the patient. So every risk or every harm they can stop. So here nursing instructors or department role is crucial. They need to be make efforts to make their nurses competent, and they empower them with the competency building. So what competency building is actually? Competency building is the structured process for developing and strengthening the skills, abilities, process, and resources necessary for the safety of chemotherapy patients. Many clinical evidences suggest that chemocompetent nurses implement policy and procedure. They can prevent chemotherapy administration error and can improve patient safety when they raise the standard of excellence in care. So what we did actually to improve or to develop our competency building, this is the scheme we followed. We identified our lapses and effective practices for preventing, managing, and responding to the risk with the potentials to the cause fatality, disabling illness, or injury. We gave context-based in-service training in actual environment to the nurses. We provide expert preceptor support to every nurse on one-to-one basis, matching with their level of staff competence. We updated cytotoxic workshop certification yearly. We made possible to refresh cytotoxic competencies yearly, and we actually empowered nurses to identify risk, and we applied the risk identification strategies as well. For new nurses, we specially developed learning contracts for them. And this is a sample of one of learning contract, and that goes week by week development of new nurses. These are the specific competencies of which were crucial for staff development in Chemo Bay. We worked on the competency of peripheral IV line because it saves the externalization, and central line. And for medication competencies, our major focus remains on 5 rights of medication and independent double check for high alert medicines, those who are included in pre-medicine. And this is our big strength, that cytotoxic drug workshop and management workshop actually is 2 days workshop, which is in 16 hours almost. Here we build the knowledge of the nurses about the chemotherapy, about the side effect, and we demo the stabilization and spillage management, and we take back the back demonstration from them. And for cytotoxic competency, we pass our nurse after 3 successful attempts, and our major focus to develop them to have habit to have second verification from the competent nurse. That's called independent double check. And for the 5th thing is chemotherapy policy and competency checklist, which is newly developed and very, very helpful for to work on it. This is a snapshot or a cytotoxic drug administration checklist. And here is a policy of cytotoxic drug administration. And in 2019, we improved. We improved in the meanings of our total error reduce and near miss increase. We detect the harm before reaching to the patient. In that year, total 43,981 patients received chemo, and there were 135 error reported. Among them, there were only 10 patients who got errors, though it was not that lethal. But there were 84 patients, those who were, we prevented the harm reaching to them. If we see the comparison, here is a very clear snapshot which shows that in 2017, in whole year, there were established errors 23 that was raised, and near miss was low. But when we did the proper competency building, we have noticed that established error reduced and near miss increased. These were the harms which we prevented before reaching to the patient. Total patient were 84, and we save our 4 patients from getting wrong patient's medication, and we save 18 patients from wrong orders. There were 9 patients, those who have a BSA calculation miscalculation, we did recognize early. Our nurses were able to recognize wrong route administration cases, and we corrected.
Ms. Muqaddas.
Yes, sure, ma'am. And there was a 5 consent, and there was a contraindicated medication for 3 patients, which our nurses were able to recognize. And there were 3 patients wrong dilation, wrong duration 1 patient, wrong medicine 16 patient, and wrong dose 18 patients. We did the reinforcement by sharing our achievements with chemotherapy nurses. They are the stakeholder, they are the bedside nurses. And we do recognize their efforts, and we continue our practices of developing them. And we continue in-service teaching for briefing, debriefing, and education. And we do the departmental quality improvement. And we appreciate good habits and warn for wrong and malpractices. If I conclude that chemotherapy administration has a high risk of harm if given wrongly, therefore it requires proper step-by-step standardized training of the nurses. SKM is recruiting nursing from general setup. So for making them chemo competent, we use a systematic approach that made them competent and enable them to recognize and prevent the risk before they happen. These are the references. Thank you very much.
Thank you very much, Ms. Muqaddas, for enlightening us and your efforts to improve our nurses in chemotherapy administration. And please stay with us and enjoy the sessions. At the end, we will have question and answer sessions. Our next speaker, because the theme of this session is oncology nurses capacity, competency building for quality and patient safety. Andrew have enlightened us, telling us what is nurses' role in patient safety. Muqaddas told us the efforts we are doing to improve patient safety. Now, Basharat, Mr. Muhammad Basharatullah, nurse manager of surgical services. He will, and he's working at Shaukat Memorial Cancer Hospital. He will talk about staff motivational factors, because for working in a cancer setup, particularly, we need to have a motivated staff. So the forum is over to you, Mr. Bashar.
Thank you, Ms. Rehana. Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon to all the participants who are listening to this conversation using their devices. So since morning, we are talking about high quality cancer care and safe nursing care. Yeah. So safe nursing care. This safe nursing care is not possible without motivated staff. So I'm going to explore some of the factors which can motivate the staff, and we also talk about some of the factors which we think that they motivate, but actually they don't. So the overview of presentation, I'll talk about the Herzberg's 2-factor motivation theory. I'll share the results of a pilot survey. We'll conclude and make some recommendations as well. So in this slide, if you can see at the right side, there are factors which are known as hygiene factors. And on the left-hand side, there are motivating factors. So the hygiene factors are those factors which decrease the job dissatisfaction. They actually do not motivate the staff. They decrease the job dissatisfaction. And if you can see here, right below the hygiene factors, there are some examples. For example, working conditions. Most of us, we don't realize that we are working in an environment which is where optimal temperature is available. But if we are working in an area where AC services are not available, then we will realize the importance of that. But currently, this is like we are okay with it because we never think that this was a very important thing. Similarly, relationship with co-workers, policies and procedure of the hospital and institutions, and the quality of supervision which we provide to our staff, the kind of management we are doing with the staff. I think that that is a big concern for the staff as well. I'll show in the survey results. And last but not least is salary. Generally, we think that when we increase the salary, staff should get motivated, but it's not the case. Maybe it's very temporary. After a few days of salary increments, people don't really think about it. So these factors, which are known as hygiene factors, they are very important. They decrease the job dissatisfaction, but they are not the only things which can motivate the staff. So what are those factors? So on the left-hand side, you can see here the job satisfaction influenced by motivating factors. And these factors are achievement, for example. So when the staff feels that he or she has achieved something while working in an area, they will get motivated. When they feel that their work is recognized and rewarded, and some important responsibility is given to them, or the work itself is so great that they like doing it. And there are chances of advancement and personal growth. So these are the factors we need to focus on for motivating the staff. So for this, I conducted a small online survey. I sent out some online questionnaire to a convenient sample of 212 staff members around the country. And these are the results I received. So some demographics, you can see the most of them are female staff working in private institutions, and most of them are married. So predominantly, the qualification is general nursing diploma, more than 52%, around 52%. And so 31% have done their 4 years BSc nursing degree, and around 12% have MSc nursing or some other kind of master's level qualification. So here you can see that the respondents, like 2/3 of respondents have experienced more than 5 years. So these are the questions, and you can see above there is a theme. For example, for recognition, majority of the staff think that their organization values their work. But here, so these 1, 2, 3 actually denotes that 1 is for totally disagree, to 5 is strongly agree. So if there are more number, it means the higher number means that the staff agrees to this. So here you can see the majority of staff think that their work is recognized, but we need to focus on this area as well. This is 17% is a good amount, a good number of people who think that their work is not recognized. So I feel that the community values my work. Again, majority thinks that community is valuing their work. But again, you can see here 15, 16% people think that their work is not recognized. So the next theme was opportunities for advancement. Excuse me. So you can see a mixed response here. Around 1/4 of the staff members think that they do not have sufficient opportunities for promotion. Majority think that they have the training. Same is for coaching and mentoring access. So here comes the problem. So the question was, my workload is reasonable, and you can see here that 1/3 people think that their workload is not reasonable. Around another quarter think is in the middle, they can go either way, and only small percentage think that their workload is reasonable. So we really need to do something about this area. So it's a right of the staff that they should go on meal breaks, but still there are around 18% people who think that they cannot take meal breaks. Majority think that their skills and experience match their job. Again, job description is clear and up to date. I think very good results here as well. I'm not worried about losing my job. And here you can see that a good number of staff think that they are worried about losing their job. So I think this is again an area where we can work. So it means that if staff is worried about losing their job, so they won't be satisfied. Annual performance appraisal is fair. So quarter of the staff think that their appraisal are not fair. Salary package, similar numbers. When they compare to their salary to other staff, again, you can see a very similar number. So again, a good 20-25% staff think that their salary is not fair as compared to other staff. Similar with the benefits like transport, housing, duty allowances, etc. So this is a point of concern for all the managers and employers, that I'm actively looking for a job in any other organization. And you can see around 40% of the staff members, they shared that they are actually looking for another job. So if we do not motivate them properly, if we do not work on them, we certainly will lose them. Supervision. Another very important thing, my supervisor applies organization policies and practices fairly, and 20% think that it's not the case. Supervisor available, mostly, yes. So work plan with a supervisor, yes, again. Head of the facility is competent. Majority think that the head of the facility is competent. So then I asked some of the questions for some of I gave some of the factors that they have to rate them on a scale to 5, that which factor was most motivating for them. The number was salary, and here you can see that 20% actually, 19% strongly agree that salary motivates them. So here, good 34% is just in the middle. But as compared to salary, job stability is a higher motivating factor, as shown by these numbers. Same goes for performance recognition and teamwork. So some people think that less time, work timings may motivate them, but not all. Gratuity and retirement benefits. Again, this is also, some people think that this also motivates them. So behavior of my supervisor affects my motivational level. Here you can see, good 42% strongly agree, and another 26% agree. So a vast majority clearly thinks that how they are treated by their supervisor or manager, that motivates them, or the other case. So opportunities for further education, again, very good majority thinks that it motivates them. Attractive designation. So at the end of the questionnaire, there was an open-ended questions for suggestions, and I collated these suggestions into some themes, and I'm presenting these themes. The first one was open and clear communication between the management, employer, and the staff members. So management can tell them their vision and how they want the staff to work, and staff should be able to voice their concerns. So there is a two-way communication between management and the workers. Appreciation and work recognition. I think this was written by majority of the staff members, that appreciation and work recognition should be increased to improve the staff motivation levels. Improve supervisor behavior, and especially to avoid favoritism and discrimination. It can be based on the religion or caste, any other thing, gender. So any kind of favoritism and discrimination should be avoided. Provide education opportunities. Some staff suggested that as well. Then staff think that they are burdened by the documentation. So and they cannot actually do their job properly, because most of the time is consumed in the documentation. So they want to decrease the burden of documentation so they can spend that time with their patients. Improving work-life balance. Sometimes we have to work beyond working hours. So work-life balance is very important again for some of the staff members. Provide financing opportunities. Some staff suggested that the employers should finance for example, if they want to buy a car or a house, there should be financing opportunities as well. increasing salary and benefits was again suggested by some decreasing workload, and promoting quality, equality and teamwork, because this motivates a lot, a number of staff. So what is the key to motivation? So based on these suggestions and the survey results, so I would like to recommend that there should be a two-way communication between management and staff. So the staff is able to to inform the management about their problems and what do they think that was right or not right. And then showing empathy. It's not only for the patients. I think the management and the supervisors, the institutions should show empathy to their staff as well. If they think that they are working long working hours, they should compensate accordingly. Then we should not just concentrate on the hygiene factors, because as we have discussed earlier, that the hygiene factors, they just decrease the dissatisfaction. They don't motivate you. So just working on the hygiene factors and thinking that we are working a lot for the staff, I think that that is not enough. We have to actually come up with motivating strategies, and we have to then analyze the effectiveness of those motivating strategies. So I have written here that the data-driven motivating strategies should be used. So we know that what are the strategies which are working for the staff and what are not. So we should work on those strategies which are actually increasing the staff motivation. And when I was going through the literature, I think in Pakistan, there is a dearth of literature about this topic. So we need to do further research into this topic, so we actually know the specifics of our population. Thank you. These are the references.
Thank you very much, Mr. Basharat, for your presentation on motivational factor, and I know that it has a great deal of question arising in people's mind, and administration, management, particularly nursing management, have to look into in different situations. And I'm sure it's not the case only in private or high burden hospital, it's the case in public sector as well. So please stay with us for question and answer session. Our next speaker is Miss Zora Asif Jeta, our good friend from Khan University School of Nursing, and she's a nursing instructor, senior nursing instructor there. Zora has a research paper to present on quality of life of spouses of women with breast cancer. Thank you for joining, Zora, and thank you for sending your work to us. Hopefully we will enjoy it. So forum is over to you.
Assalamu alaikum. Bismillahirrahmanirrahim. Assalamu alaikum. My name is Zora Asif Jeta, and I'm working as an instructor at Aga Khan University School of Nursing. And the topic of my presentation is quality of life of spouses of women breast cancer. So this is the outline of my presentation. Globally, breast cancer is one of the most common cancer. Pakistan has the highest rate of breast cancer among the other Asian countries. The nature of life-threatening disease and unpreparedness to handle for the new task directly affects the spouses. Moreover, insufficient social support disturb marital relationship, and the exertion of the daily life activities may impact their quality of life. So why I chose this topic for my literature review? Because while working as a breast cancer nurse, I always observe that women mostly share that how they get affected from their husbands after the diagnosis of breast cancer. However, these following words change my thinking. And these are the words which is shared by one of the patients whose wife was diagnosed with breast cancer. I am a man and I am not allowed to cry. I am a breadwinner, so I have to earn money for the family. I was unprepared to take the responsibility after my wife's illness. This emotional and physical stress making me tired. The fear of losing my loved one doesn't allow me to sleep. I guess sometimes I feel like I am on call 24 hours. I am feeling helpless. Moreover, working as a breast cancer nurse, I have also observed that when women are diagnosed with the breast cancer, certain factors affecting on the spouse's health. For example, age of the couple. If the couple is young, it directly affects on their sexual life. If the number of the children and their ages, if they are very young, then the workload increase for the spouses and they feel tired physically. The more advanced stage, the more fear of losing loved one. It impact on their psychological health. All the time they feel fear that we don't know that what is going to happen in the next day. Instability of the financial condition, as we all are very well aware that in Pakistan we don't have the healthcare insurance system. So mostly when the people in the family diagnosed with any tragic disease, mostly male have to take the loan to treat the family member, and it increase the frustration. And lastly, the culture. So when women are diagnosed with the breast cancer, usually male have to work for the family and also to take care of the wife. And society impose lot of stress on the male that why are you taking care of all the work which is related to the female? So why don't you leave her and you can marry it again? These all are making them feel loneliness, neglected, fatigue, despair, worried, angry, and many more. So I start searching literature to see my observation, and I search literature through electronic database. And fortunately, I found the literature which supports my observation. I found the literature that the spouses remain strong in front of their wives, children, and hide their feelings and their issues. They build emotional disturbance, changes in daily living, balancing home and work life, taking care of children, financial adjustment, and disturbed marital relationship. Due to unavailability and inadequate support from the society, they deal issues by their own. And this all increase harmful consequences on their quality of life. I would like to share some of the quotes which I have taken from the literature, and these quotes again support my observation. It was difficult to experience feeling pulled in two different directions, home and work responsibilities, and this sometimes left me feeling irritable and frustrated, and less patient with others in the workplace. I stopped mixing with my coworkers and neighbors because my wife's disease, because I don't want them to ruin my wife's moral with their words. Since my wife has had breast cancer, my family has put me under pressure several times to leave my wife and marry another woman. After this disease, I feel that our lives are disintegrated. We were no longer living as before, and we were only thinking about the treatment of my wife. Dealing with the responsibility that she may not survive this has changed my life, my emotional life. I have considered life without her, it is not pleasant prospect. And many other quotes were in the literature which says that men are feeling lot of stress, lot of burden on their shoulders when their wives are diagnosed with the breast cancer. Unfortunately, I have not found much literature in Pakistani context or in Asian context. So probably the in Pakistani context, the informal caregiver role is not limited to the spouse only, because we know that we have extended family system where the role is distributed among the sisters, brothers, father, or in-laws. Men are culturally brought up with the mindset that they are very strong. If we just remember, then if we have a one boy and one girl in our family, we always say that boys are not never cry. You are a man. How can you cry? So they learn this behavior from the beginning. They don't, that is the reason they don't share their problems with anyone. And they hide their issues and they keep them with themselves. And sometimes they don't feel to share, to say anyone that they have any financial or any other issue. They are stigmatized as weak or unmanly if they perform their partner's task. That you now you are feeling like a bivi ka gulam. So, the detailed exploration of this topic in Pakistani context will help the researcher to plan the intervention. Healthcare professionals should plan holistic couple-based intervention, which include therapeutic communication. Because when patients are coming in the clinical, usually our communication matters a lot. Sometimes we show some non-verbal gestures so they can affect on the couple and they may increase their frustration. Providing knowledge about disease. So when sharing the information about the disease, we have to be very careful that we do not use jargon or difficult vocabulary which may not understood by the patient's family, because we are medical people, so we used to say many medical words and which are very difficult to understand a layman person. And then showing empathy, as Bisharat said, that empathy is a very, very important component. So it's not only for the patient but it is very important for the family to listening them, to giving them support that you are there to help them. It's very, very important. Partner counseling. So when my wife is diagnosed with the breast cancer, it is very important the counseling done by the couple. Both couple should be husband wife should be there and the counseling can be done. Support group, this support group help the person for the socialization to see the other person's issues, because when someone is going through some issues feel that I'm going through a lot of issues, but sharing this information with other feel that someone else is also sharing the pain. And the last, don't being judgmental. Please do not be judgmental to use the judgmental words by looking the personality of the person without knowing the whole story. We never have to use kind of words or and gestures which may affect the person or make up on. So I would like to end my presentation over here with this quote. And this quote was shared by one of the cancer survivor. And this quote is the evidence that how husbands are taking care of their wives. I wish no women should have to make this choice, but my husband's support was unconditional. He told me that he will stand by me no matter what path I decided to take. Thank you. These are my references. And thank you, Ms. Rihanna, for giving this opportunity to share this topic in a very good forum. Thank you.
Thank you, Zara. It was really nice, and I always appreciate all the nurses working in oncology setup to bring their work out. So please stay with us for the rest of the session because we have question and answer in the end, and I hope you will enjoy. Our next speaker is again from Aga Khan University School of Nursing, Aga Khan University Hospital, Karachi, Pakistan. This is Ms. Nasreen Rafiq. Ms. Nasreen Rafiq is going to present her work on nurses' perception about the dignity of intubated patients in the intensive and critical care units of tertiary care hospital. Ms. Nasreen, floor is over to you.
Thank you so much. And Assalamu alaikum. Bismillahir Rahmanir Rahim. This is Nasreen Rafiq. And before starting my presentation, I just want to mention that intensive and critical care has always been my passion. And I love to integrate this intensive and critical care with the concepts of ethics. So my presentation for today is also an amalgamation of both of these ICU setup and the nursing ethics. So I hope you people will enjoy listening to it. So let's begin with this. Imagine yourself in an intensive care unit, being sedated and intubated with a tube inside your
Your
trachea.
slides as full.
Imagine yourself in an intensive care unit, being sedated and intubated, with a tube inside your trachea and your mouth being undesirably open. Imagine yourself being surrounded by ventilators and other big machines. Imagine yourself in a diaper soiled with feces and your body stinking with smell. Imagine that you want to get rid of it, but you cannot move. Fortunately, you felt your nurse checking your diaper and removing your trousers to clean you. However, you also hear another opposite gender staff talking to your nurse when you are naked. You want to communicate and stop your nurse, but you cannot. Here, you question that do ICU nurses really know about dignity? Honorable examiners and chair, respected audience, and dear colleagues, Assalamu alaikum. My topic for this presentation is nurses' perceptions about the dignity of intubated patients in the intensive and critical care units of a tertiary care hospital in Karachi, Pakistan. So here comes the background of my study. Dignity is derived from the word dignus, which means worthiness. The intubated status of ICU patients makes them dependent on nurses not only for critical care, but also for intimate care. Hence, certain aspects of routine nursing care can turn out to be challenging for the dignity of intubated patients. The dignity in patient care has become more important with the contemporary increase in the use of technology in nursing care, particularly in the intensive and critical care settings. The use of complex technology consumes most of the nursing focus at the cost of patient care. Moreover, the life-threatening environment of the high dependency areas with the demanding workload prioritizes the management of acute conditions and overlooks patients' dignity. The Universal Declaration of Human Rights affirms that every individual, sick or healthy, has the right to speech and autonomy. Yet, often in the intensive and critical care units, due to endotracheal intubation and commonly sedated status, patients are unable to communicate or practice their autonomy, which threatens their dignity. Although intubated patients are dependent and have altered levels of consciousness, they remain human beings with dignity. Nurses, being the central care providers, become the stakeholders in the promotion of patients' dignity. Therefore, the understanding of nurses' perceptions becomes important for exploring the phenomena. Hence, the study aimed to explore nurses' perceptions about the dignity of intubated patients in the intensive and critical care units of a tertiary care hospital in Karachi, Pakistan. Methodology. The study utilized a qualitative descriptive exploratory design. Total 14 intensive and critical care nurses were recruited through purposive sampling technique. The data was collected through in-depth individual interviews with note-taking, and Creswell's method was used for analysis. All ethical considerations were ensured. The analysis of the findings led to the development of 4 themes. The first theme described 2 different aspects of existing nursing practices based on the participants' explanations of dignity. While caring for intubated patients, 2 different yet important clarifications about dignity in intensive care emerged. The participants defined dignity of intubated patients as both the humane and technological responsiveness in the routine care. These explanations indicated that dignity is inculcated in both the art and the science of nursing. Theme 2 highlighted the potential benefits of dignified nursing care to the intubated patients, to the intensive and critical care nurses, and to the entire healthcare organization. A participant said, and I quote, "Believe it or not, intubated patients remember everything. They are listening to you. An intubated patient said to me after getting extubated that I had no hopes. You nurses motivated me by your optimistic words. I could feel you people. You instilled hope. You gave me life. The more you treat them with dignity, the earlier you'll see them recovering." Unquote. The study findings under the third theme highlighted various conditions which threaten the dignity of intubated patients and challenge the provision of dignified nursing care in the intensive and critical care units.
4 more minutes, Ms. Nasreen.
The analysis, sorry?
You have 4 minutes.
Finally, in theme 4, the analysis of the findings proposed various strategies at the organizational and individual level to overcome the challenges and promote the dignity of intubated patients. The study findings led to the modification of the Dixon's conceptual framework of dignity and contributed to the development of a contextually modified framework of dignity. The dotted lines in the framework represent the contextual modifications. Future recommendations. Florence Nightingale said, and I quote, "The very first requirement in a hospital is that it should do the sick no harm." Unquote. This quote further strengthens the basis of dignity and also paves the way to the role of advanced practice nursing in the critical care nursing and nursing ethics. The implications for this role can be related to education, practice and policy, and research. The nursing curriculum needs to be revisited to ensure an equal focus on the art and science of critical care nursing. Dignity should be incorporated in care policies to govern professional practice. Continuous professional nursing education should be ensured to improve the nurse's knowledge, attitude, and practices in order to build nursing capacities and promote patients' dignity. Finally, future researches should be conducted to evaluate the impact of dignity in critical care. So these are my references. And in the end, I would like to acknowledge Dr. David Arthur, Ms. Shirin Rahim, Dr. Yasmin Amersi, and Dr. Yunus Durangu, and Mr. Anis Khwaja for their constant support. So this marks the end of my presentation, and I would like to say thank you to all of you for listening to me and giving me this opportunity to speak on this platform. Thank you so much.
Thank you so much, Ms. Nasreen, for bringing this unique topic to nursing, dignity in critical care, and it was really, really enjoyable and really thought-provoking topic. Please stay with us for question and answer session. We have a last presentation. Here I'm going to introduce Ms. Daisy Jaffer. She is working at Mohyuddin Islamic University, Azad Kashmir, Pakistan. Hello, Ms. Daisy. Daisy will present her work, Self-Esteem of Patient Receiving Chemotherapy Treatment in Tertiary Care Hospital, Karachi, Pakistan. Ms. Daisy, floor is over to you.
Thank you very much, Ma'am Rehana. First of all, I would like to say good afternoon to all participants. With that, I just want to clear that I have resigned Mohyuddin University, and last month, 1st of October, I have joined Rawal College of Nursing as principal. So this is my little introduction. With that, I would like to share a screen here.
Okay, so maybe when you submitted your abstract or the work was from Mohyuddin.
Yeah, actually it is, but I forgot actually I just forgot to tell you about my new status, so that's why it is the previous status. So thank you very much once again for providing such a beautiful forum to all the nurses, especially sharing the perspectives on oncology nursing. The topic today's my oral presentation topic is self-esteem of the patients receiving chemotherapy treatment in Tertiary Care Hospital, Karachi, Pakistan. This is the presentation outline, and the background for presentation is that cancer is becoming serious health concern and health problem in public around the world, and cancer impacts on psychological well-being and causes stress. And according to WHO in 2018, it is estimated that 9.6 million deaths accountable because of the cancer, and it is the second foremost cause of death in globally. Okay, globally, 1 in 6 deaths is due to the cancer, and in Pakistan, one of the primary causes of death is cancer, and it is accounting 8% of all deaths in Pakistan. Cancer not only alters the physical and psychological well-being, but it is causing altered status in occupational aspect and family life because of expenses in the medicine. Family may go in the crisis of financial status. Chemotherapy results in a number of after effects comprising motion sickness, vomiting, diarrhea, reduced desire of food, and hair loss. Different quantitative studies have recognized that guilt and sadness occurs when self-esteem is lost because of hair loss. As you may can observe it that our body image is one of the main aspects when you are dealing with the public meetings, especially, and you are going to attend the social activities. So here is the study objective, that it is about to assess the alteration in self-esteem after receiving chemotherapy. According to some literature which I have found regarding this subject, this is that altered self-esteem results in minimizing social activities and while meeting people. And anti-neoplastic chemotherapy delivers abundant disadvantage to the patients of malignant and non-malignant cancers. It is observed that during treatment, the most emphasizing part is psychological imbalance, because psychological imbalance creates stress-related factors or effects after having chemotherapy, which then alters the self-esteem level of any individual. And other study I would like to share here, that different other study perspectives we have, that cognitive pattern when you are receiving chemotherapy is also altered, and it may have effects of memory retention, attention, and processing of information in daily life. It is also seen in breast cancer patients that when they have mastectomy, the physical appearance is also impaired, and which may influence negatively on the body. This is my research question, that what are the factors associated with self-esteem? So this is the study method overview, where the study setting was general and private wards, daycare, OPD of an oncology facility, and the target population was patients suffering with cancer, and the study design was descriptive cross-sectional. This study was conducted between May to September 2017, and the sample size was of 50 patients, and the Rosenberg self-esteem scale was administered to all individual participants after having their voluntary consents, and the sampling technique was consecutive. This is the inclusion criteria, where patients who were admitted in oncology facility diagnosed with cancer, patients who were attending daycare facility for their chemo cycle, and the patients who signed their voluntary consents. And all those patients.
5 minutes, Miss Daisy.
Okay, sure. And all those patients who did not sign their consents were excluded from this study. The questionnaire was self-administered, and the data was analyzed on SPSS version 22, and the self-esteem levels were calculated manually. The ethical consideration was taken from Ethical Review Committee of Ziauddin University College of Nursing, and of course the Internal Research Committee, and the permission was also taken from the data collection sites, and the written consent was from each participants, and the autonomy of the privacy and confidentiality were also followed. This is the validity and reliability. As I have told you that Rosenberg self-esteem scale is already used in the different other international studies. So it was a validated tool or instrument, and then it was again refined by fulfilling by 3 oncology nurses before administering to patients. Here is the table 1, which is showing the frequency of demographic characteristics of study participants, where 56% of the female were with highest frequency in gender, whereas 51 and above years of uh, uh, were the participants with 66% of age. And for income criteria, there is 10,000 to 60,000 of the income with 38%. This is table 2, where we have total 10 items in Rosenberg self-esteem scale, where initial 5 items are about the positive self-esteem and the feelings, and from 6 to 10 it is about the negative feelings of self-esteem. And the scale is on this is the Likert scale from strongly agree to strongly disagree. Here we have self-esteem levels, and we just got average self-esteem level of 46 patients suffering with having chemotherapy, and there were 3% of with low self-esteem and 1% with high self-esteem. Some factors associated with self-esteem were hope and spirituality were in average self-esteem, anxiety, weakness, irritability, guilt, increased burden in daily living with low self-esteem, and self-assurance, emotional steadiness, and good thoughts were with high self-esteem. Here is the limitation. Of course, there was time restraint, and the population was restricted to one oncology facility of Karachi. And some future directions, I would like to share that there must be longitudinal studies to assess the self-esteem level in the beginning, middle, and end of receiving chemotherapy. And the psychological rehabilitation should be continued thoroughly sessions of chemotherapy, and nursing staff should plan strategies which maintain a self-esteem level of patients. The
Thank you, Ms.
conclusion of the
Stacy.
study.
Thank
Yes, ma'am.
you. Yeah,
Okay.
because I'm short of time, I'm afraid that our system may not close. We want to take few questions. So I would like to invite Ms. We have questions to the two speakers. One is question is to Andrew, and one is to Ms. Muqaddas. And then there is a question to Mr. Bashara. So may I request the speakers of session 2 to please put on your videos and so question number 1, I think, can you hear me? Can you hear me? Oh,
Yes.
our Zoom is open. The question number 1 was to Mr. Andrew, where the participant asked how you make the bedside nurses to raise their voice for patient safety and quality. So please elaborate.
Absolutely, that's an excellent question. So on a day-to-day basis, what we do, we have just introduced quality and safety boards in every clinical area, including outpatient areas. So what we do, we have all the patient safety indicators or quality measures, including patient feedback. And on a day-to-day basis, the nurse in charge will gather all of the nurses, currently socially distanced, but looking at all the data for every day. So the nurses all know how many pressure ulcers, falls, etc. So we encourage each nurse who's looking after each patient to identify which patients are at risk, which quality indicators we need to address. And again, that's done on a day-to-day basis. So it's giving that nurse a voice, and then also on the round. We also do a weekly clinical forum with its multi-professional. So again, sharing that quality and learning. And I'm happy to share one of the pictures of the boards with you if that would be useful.
Okay. Thank you, Mr. Andrew, for elaborating the answer to the question. Next question is to Ms. Muqaddas. Ms. Muqaddas, people think that it was so good study you presented that you were improved in error reporting through near miss, and you reduced the error. But there is a question. Could you please identify the factor for that few errors were still happening despite having all those efforts? So how can we reduce those?
Yes, that is very good question. Actually, we analyze those errors which happened in 2019, even in spite of many efforts and empowering and training the staff. But as I said in my one slide, and standard says that intercepted errors or human errors can happen. These are unintended. Our effort is to know the risks and train the staff. This is a motto of our training. So we try our best. So human error cannot be stopped where human are working.
Error is human. I will like to add. And second thing is that because the unit is doing its best to develop capacity, but because of high turnover and getting novice nurses from the market and preparing them to work in chemotherapy administration is a big challenge. So this could be one of the factors which is there. There's another question to Basharatullah, and that is, how many motivational factors are you using in your department to increase the productivity of your staff?
Thank you. That's a very direct question to me. So yes, yes. So enlisting the number, I think would be difficult. But then one thing which I am practicing is the first thing I mentioned in my presentation as well, that there should be a two-way communication between the staff and the manager. So my personal number is available to all my staff. They can contact me anytime. They can share their whatever they want to. Even sometimes, I mean, after hours, I get calls and messages. So I think this is one of the things which I'm really proud of, that I'm available to them. The other thing is that they should feel actually that they are treated well, and I'm trying to do that as well. So
we have a staff satisfaction survey, Sharat, in all the around across our hospital, which includes your department, and our results are really promising to those factors which are really motivational. And of course, and we in our staff satisfaction survey every year, because of JCI, we are doing it every year because we are JCI certified environment. So we found that people actually ignore hygiene factor. They really want to go for the others, and we had a good responses on those.
Thank you, Mr. Hannah, for highlighting this. Just to add that our results are comparable to international benchmark. We are actually doing, we are doing well as compared to the international benchmarks. Thank you.
And similarly, we have a patient safety survey, which is done again as a per requirement of JCI. And in that, we receive our staff talking about patient safety and view. They raise their voice. They are empowered to talk to the consultant and tell them, even in our culture in Asia, that, oh, you haven't washed your hands. Oh, I would not let you go in until my patient is totally covered. Oh, this medicine you have entered is not correct. Please correct. So all these things are happening. Nurses are really, really coming to the patient safety. Thank you very much for all. I will like to conclude that we receive a lot of good comments on all of your presentation. You all did a very good job. And actually, you made my day a successful day. I'm so thankful for having this nursing session with you. And most of you will receive call from me again for year 2021 to be the presenters. And all those comments which are sent to you, whoever is interested in the audience, they can ask for the email address. And if you like, I can share your email address with them, and they can directly be connected to you, because the purpose of this symposium is educational, as well as the purpose is to build networking among the oncology nurses for future and to learn from each other. So thank you very much again. Thank you. And have a very good Sunday, half weekend. Okay. Thank you.
Absolutely. Thank you very much.
Thank you, everybody. Thank you so much. Good night.